Welcome to the Acupuncture Outsider podcast. My name is Richard Hazel, and in the time it takes for you to commute to or from work, I hope to have shared something of interest about orthopedic acupuncture using motor points, trigger points, myofascial slings, neurofunctional acupuncture, segmental treatments, anything that crosses my mind that seems to be of interest. I hope you'll enjoy it. Hello and welcome to another episode of the Acupuncture Outsider. This is Richard Hazel, and today I want to talk about some foot neuropathy successes and see if I can give you some tips that have helped me with some patients. Off the bat, I just want to say that I am not an expert in treating foot neuropathy, but when someone has it, I make an attempt to help them. And I've learned some things over the years of trying to help those people. And I'm specifically thinking about numbness, tingling, cold or burning sensations. Not maybe another time we'll talk about other things like foot drop and things like that. I did something about foot drop before, and but I don't want to talk about the motor nerve. I want to talk about sensory nerves. So I've recently had some successes that came about because of me, experimenting a little bit. Foot neuropathy, foot numbness or tingling or cold or burning. People tend to have all of those symptoms at different times. It's as complicated as treating migraines, because there are just so many ways to get foot neuropathy. So you can't say I always do this or I never do this. You kind of have to know the patient's history and make some educated guesses about how to best start treating those patients. And they may have numbness only on the bottom of the feet, or they may have numbness on only part of the bottom of their foot, or they may have cold feet. They may have numbness on the top of the foot. So everybody's different, and that's what makes it hard, is because I can't say always do this. What I've learned, though, which I wanted to share, is regardless of what I'm going to tell you, like what points I use or whatever, because there's no set protocol that I'm aware of, which is why I've had to sort of study it on my own and try to figure out the best way to treat. I would say always remember that the numbness can be a combination of nerve entrapment and vascular issues. So, and I really think, do not underestimate the ability of ischemia to cause numbness and the ability of ischemic muscles to entrap nerves. So, after a period of time, I really had some poor luck, really bad luck trying to help people with foot numbness or foot burning after chemotherapy. And I'll just say, I don't treat anybody who's being treated for cancer because they need to be able to heal for me to help them. So this is like once they're in remission and they have foot numbness, I've tried to help people and have had a lot of failure with it. And I recently started to see better results by treating it as ischemia more than nerve entrapment. If you're familiar with the plantar nerve podcast, where I talk about how the tibial nerve splits and becomes there's a plantar nerve that goes into three branches at the bottom of the foot as sensory nerve. The plantar nerve is motor and sensory, but the sensory part is obviously the one that I'm concerned about for numbness. So there are different branches. So you're always wanting to consider like what which branch or branches are most affected. There's a heel, there's a medial foot, and then there's like a lateral plantar nerve that affects the bottom of the outer part of the foot, and usually toes 4 and 5, especially 5. Um, so you kind of want to get a sense of that, and I have noticed that when people have numbness on the bottom of their foot, they very often do have extremely tight plantar flexors, like the tibialis posterior, which can cause that tarsal tunnel issue. They'll have ischemic toe flexors. They'll have ischemic adductor, um, abductor hallucis, like where one of those branches can get entrapped. They'll have really tight dorsiflexors, like their tib anterior, extensor digitorum longus. Their peroneals are tight. Um, People in their 60s and 70s have just ischemic low leg muscles. And the ones that I'm treating for neuropathy, it's extreme. So, and I probably talked about that, like, needling tibialis posterior on a 70-year-old who's had some sort of lumbar radiculopathy, something that caused, um, sciatica, perhaps. Their plantar flexors are like a rock, and they have really terrible blood circulation. So I've had some success treating post chemotherapy foot numbness by making sure I'm treating anything that I feel is going to be helpful for cold or numbness in the feet, and that's a lot of the plantar flexors. And don't forget soleus and gastrocs, because the soleus is huge for pumping blood back up to the heart. So the soleus needs to be able to help circulation as well. So even though it doesn't go into the foot, it is important for circulation. So soleus, do not forget soleus. I try to help gastrocs too, just for functional purposes. But I've seen better success by thinking about the vascular aspects of post chemo foot numbness than just nerve entrapment. Now, when somebody's had some sort of radiculopathy, like a sciatic L5S1, for instance, they'll have the weakness often in the muscles as well as numbness. So then I'm treating both. One really common one that is not that hard to help or to correct is the sensory, the peroneus cutaneous nerve, the peroneal cutaneous nerve. So you know how you have the deep peroneal nerve that helps a lot of the foot drop muscles. The superficial branch of the peroneal nerve is sensory. Well, it's motor for the peroneus longus and brevis, but it's sensory for the shin into the top of the foot. So the dorsal foot and the front of the leg on the lateral part of the tibia is the peroneal cutaneous nerve distribution. And you'll see that numbness on people who've had sciatica. Maybe they've had some sort of impact injury that affected the fibula. Those people, I find, you can help really quickly. Sometimes you only need the motor point of the peroneus longus and brevis for like up to 10 minutes. Some people will have a good result just from that alone. Some people won't. And in the case that the motor points were not sufficient, you're likely going to be palpating near the head of the fibula for ropey bands in the peroneus longus, the upper peroneus longus. That seems to be the entrapment zone that I find. And I will then dry needle, but I have to, the nerve is there. There's like nerves there. You don't want to zing the nerve. So you're going to go cross fiber superficially from like anterior to posterior so that you're not going deep enough to hit the nerve. But you're going to feel those fibers on the superficial level usually. And if you can get a good couple twitches out of it, it's usually enough release to unentrap that superficial cutaneous nerve. So so that one I have fast, good results on. It's the lateral plantar nerve that causes the numbness in the toes 4 and 5. You'll see that a lot post sciatica. So, so that one I wanted to share that I've had better success with those patients, or I would say faster success. I've had good success with those patients all along by treating the abductor hallucis and the tibialis posterior. I rarely will needle into the quadratus plantae, which is another entrapment zone for those nerves, but very often it is an entrapment by the abductor hallucis. And I had originally been needling just the motor point that I learned from Dr. Perotto's book. You basically in the medial arch, midway, like one finger below the navicular bone, is a really good motor point for the abductor hallucis. I had very good success with a lot of people just using that, but my success rate went up noticeably when I started needling the abductor hallucis in the medial heel area. So sort of like inferior and posterior to the medial malleolus. If you were to palpate the medial heel in line with the abductor hallucis, you're probably just try to visualize how that muscle is going to go back to the calcaneus and become a tendon there. So you got to be like in the anterior third of the medial heel. So you're always going to be needling into the medial surface of that heel, probably right around where the skin color changes. And you're going to be in that first anterior third of it. You can often find a really good motor point there. When you put stim on it, you should see the muscle moving. And I think that basically, looking at images of the plantar nerves, you can see how it passes through the abductor hallucis in that posterior area near the heel. Perotto's motor point is excellent, and probably for electromyography, it's all that's needed. But there's this other one further back in the anterior heel medial area that I've been able to locate frequently that has given me faster success. And it, just for like really logical reasons, going closer to where the nerve is going to be entrapped by the muscle seems to have freed it up faster for people. So I wanted to share that because that's a recent switch up that I've made for the lateral plantar nerve numbness. Really think about ischemia for these patients. Like really think about blood flow. And No, I don't think that just a spinal segmental perfusion type treatment where you're going into like the lower thoracic and upper lumbar multifidus muscles segmentally. I doubt that's an autonomic thing, and it's not. I really, while some foot neuropathies are autonomic, I don't think that most of them are. I think it's mostly ischemia. So you have to make your decision based on palpation. If you're palpating and those muscles don't feel ischemic and tight, and you suspect there's an autonomic thing, then go for it. Try your segmental approach. Most of the patients that I see with foot numbness have ischemic muscles. So I treat that way. And I think the ischemia is what's leading to the rigidity of muscles causing the nerves to get entrapped. So I'm thinking about the nerves, the nerve pathways, as well as the blood circulation in the lower extremity. So I would treat both ways. And then I also recommend that my patients try to do something to increase vasodilation. So the doctor whose office I work in, he gives people with foot numbness a supplement that increases nitric oxide. And there are many out there. And if you look in the fitness world, like you go to a store that's more marketing toward people who are into working out, you'll see, all the protein powders and things. But NO, you'll see that a lot. You'll see NO boost or something. It'll be nitric oxide boost or some sort of supplement that's meant to increase nitric oxide. Those are a very good addition for someone where you feel like their blood circulation needs to be improved to have more warmth in their feet, more sensation. So if they can do something on their side, I also think that foot soaks are good. Like Epsom salts, hot foot soaks, or get one of those foot massagers. You can get them, like a Smarter Image type thing. You've seen those things, like they'll even market them as like shiatsu or something. But they've got these little mechanical things that spin around inside. I think that could be really helpful. Or getting foot massages, but they really need to increase blood flow in their feet to have faster results. So I'm going to try to work on any kind of sensory cutaneous nerve entrapments. I'm going to work on any of the muscles that plantar flex. Well, I actually do end up working on like lots of the dorsiflexors as well. But when the numbness is on the bottom, I'm thinking first about plantar flexors. I want to increase blood circulation to all those muscles. And I'm finding that I get really good results with a lot of people. Guidance on what to tell people. In the United States, our seniors don't typically have any kind of insurance that will cover acupuncture that isn't low back pain. And I don't want to go on that tangent, but our system in the United States, you probably heard, it's not very good. So my patients who are senior citizens are paying out of pocket. So they're using credit card. So I don't tend to want to encourage them to keep trying beyond 5 sessions. I'll tell them we really should start seeing improvement in 5 sessions. And after that, it will be up to you if you want to continue. If you're not seeing results at that point, I am not going to pressure you to keep trying, because I recognize it's a lot of money for people who are on a fixed income and they're paying, with the credit card or whatever. Typically we'll see results in the first 3. Many times on the second visit, after the second visit, they'll start to feel something. Now, for your charting, I personally use a percentage. rather than like a 1 to 10. I use a percentage. So when we start out before treatment, I want to get a percentage from them of how much sensation they have, if it's 20% or 10 or 40, because we need to be able to track improvement. And so I'm putting my hand under their foot and on top of their foot, and on each side I want to get and I'm stroking, like just gently stroking and maybe putting some pressure, because different things are going to have, input. So I'm light touch and then some pressure, and I want to get their feedback on what percentage of sensation they have. So I get a baseline before treatment. It might be 20%. And that'll help us to both agree whether or not they're having improvement. And then, of course, they'll have their random, objective sort of input about what they feel the most when. A lot of times it's nighttime sensations, burning, like it's on fire, cold, sense sensation gets upregulated. So to them, just water hitting their foot in the shower could hurt. There are different things that people will be focused on. So those are important for our baseline, because then I want to know if you feel like your feet feel ice cold at night, then I want to know if that's getting better. Recently, someone that I was treating whose feet feel ice cold at night, they feel ice cold to me too. So I'm definitely, was looking at that as a lot of ischemia. And in fact, after the third visit, a lot of the warmth has returned to his feet. I think we're up to the fourth or fifth visit now. So he's warm. His feet are now warm up to the ball of his foot. So his toes are cold, but his whole foot is not cold. And he said it's better at night. It's getting better. So I think, in that case, it's vascular as well as nerve. But I like to get those baseline things, just so we know if they are feeling improvement. If you've been doing this for a while, how patients only focus on the negative. Not everybody, but many. So as long as there's still some deficit, they're going to say it's not better. You're going to say, is it better? And they're going to say no. So the only way you can agree if it is getting better is if you have some sort of baseline, in which case they will start to say, oh yeah, I guess I'm probably starting to feel about 50%. So, it's just, you want to get those baselines so that if it is worth pursuing after 5 visits. It can take some time, but as long as someone's not plateaued, I'm suggesting that we keep moving, keep treating. That's what I'll tell them. I'm not pressuring you, but if you're continuing to feel improvement, you have not plateaued, it's worth pursuing. It's worth continuing. And like I said, I'm not into pressuring anybody, but if they agree that it's helpful, it's probably the first thing they found that was actually helping, because we know medications don't help. So anyway, I'm trying to think if there's any other tips or tricks that I've found. No, I think that's it. I think really, do not underestimate the ability of soft tissue manipulation, like with a scraper tool, like a metal IASTM tool, gently working through any of those ischemic muscles. I really think that helps. Getting those muscles able to pass over each other after they've been stuck for so long can really help. That's another thing that I think is helpful for getting their blood circulation better. You can do that on the bottom of the foot if they're not hypersensitized. I find that seems to be helpful. So those are my reflections on treating tough foot numbness and tingling and burning and cold. Um, Another time we'll talk more about the motor deficit. But I hope that was helpful to somebody, especially that one in the medial heel. Try that. I'm really loving it. So, okay, that's it for this week. And I will talk to you soon.